So today's topic will be on antimicrobial stewardship in the OPD settings. And we will be dealing with, we'll be trying to answer two questions. That is, the patient is in front of you in your OPD. First of all, we need to know whether the patient is having an infection, and if so, whether the patient will require an antibiotic. And second question obviously will be, if the patient requires an antibiotic, what antibiotic we should be choosing and for how long. This is actually data from US. It shows the situations where antibiotics are usually getting prescribed in the OPD situation. And this actually mirrors our data as well. So in the OPD, around 44% of the antibiotics are getting prescribed for acute respiratory conditions. So what does this acute respiratory conditions mean? So 25% of these acute respiratory conditions are the sinus infections, 22% middle ear infections, 20% pharyngitis, then viral upper respiratory infections, bronchitis, bronchiolitis, pneumonia, which is non-viral pneumonia, asthma, allergy. You can see that majority of the situations actually antibiotics are not necessary. And this is actually the proportion of unnecessary antibiotic use. All conditions taken together, the proportion of unnecessary antibiotic use in USA. This data from 2018 shows that in the OPD setting, around 30% of the antibiotic prescription are unnecessary. In our scenario, it might be around 60 to 70%. And USA had a target of decreasing the inappropriate use of antibiotics in the OPD by 50% by 2020. They were not able to achieve this because of the COVID-19 pandemic. So setting targets is very, very important, because even after, say, 7 days of this webinar series, etc., if you want to make a change in your hospital or a PHC, you have to set some targets. It need not be like, you should calculate the defined daily dose, nothing like that. No, you choose certain clinical scenarios like, say, upper respiratory infections, and see whether the next 1 year will be able to bring down the antimicrobial prescription for a particular infection syndrome by around 50% or so. So you can set your own targets. So this is basically unnecessary versus appropriate use of antibiotics. The red means that it is an unnecessary use of antibiotic. So for non-viral pneumonia, so 100% antibiotics are necessary. For urinary tract infection, antibiotics are necessary. But when it comes to middle ear infection, antibiotics are necessary only for suppurative middle ear infections. For non-suppurative middle ear infections, antibiotics are not needed. And this aspect will be dealt with in the last of the webinars, that is during the pediatric antimicrobial stewardship discussions. For the sinus infections, in 34% of the cases, antibiotics are not necessary. Pharyngitis also, you can see that more than 50% of cases, antibiotics are not necessary. If you look at asthma or allergy, bronchitis, non-suppurative middle ear infections, influenza, viral pneumonias, etc., in those situations, actually, antibiotics are totally unnecessary. For those situations, if you are using antibiotics, probably that is one area where we can focus on as far as curtailing the use of antibiotics are concerned. Here lies one problem, because now when you're sitting in the OPD, the issue is that in our setting, we don't have access to the point of care testing or rapid diagnostic testing, and to differentiate between viral and a bacterial sinus infections, or say upper respiratory infection, etc., we have to rely on clinical clues. So, and majority of the doctors are a bit wary, especially the students are a bit wary. They think that, starting antibiotics is like spreading a safety net. So they are not really keen on just looking at the clinical signs and saying whether it is a viral infection or not. They think that antibiotics are a safety net. So the aim of this discussion is to help you through certain situations where antibiotics are not necessary. So this is actually their outpatient antibiotic prescription reduction target. That is 50% reduction for respiratory conditions, and for non-respiratory conditions, around 15% reduction by 2020. So CDC actually has this leaflet. This is actually not meant for doctors. It is actually meant for nurse practitioners and the laymen to actually differentiate between viral infection and a bacterial infection. So it's actually a very easy slide, or easy leaflet. You can say that if you're having rhinitis, if you're having sore throat, except for streptococcal sore throat, COVID-19, influenza, etc., it is due to virus, and antibiotics are not needed. And if you look at bronchitis, middle ear infection, sinus infection, etc. It could be due to virus or bacteria. Even in that situation, you can see that for bacterial infection, sinus infection, antibiotics may be used. Whereas for situations like streptococcal sore throat, whooping cough, and all, it is due to they require antibiotics. So it clearly says that if you are having rhinitis, so antibiotics are not needed. So we should make an effort in the OPD to identify patients who are likely to have a viral etiology for upper respiratory tract infections. Then this slide we did discuss on day one. That is, when you are dealing with a patient and patient is having fever or any localizing sign, first of all, you should see whether the patient is likely to have an infection. And if you think the patient is having an infection, the next thing that should come to your mind in the OPD also is that what clinical syndrome this patient is having. Suppose the patient is having fever with unilateral facial pain plus discharge from the nose, etc. It is likely to be a sinusitis like thing. So you should have that provisional diagnosis. And next is that you should ask what is the likely organism which is leading to this sinusitis. In order to identify this likely organism, you should know a bit of microbiology. That is, for example, sinusitis. So, the common organisms should come to your mind. So, majority of the cases of sinusitis are due to viral infections, and then pneumococcus, H. influenza, Moraxilla, etc. Next aspect is that once the idea of the common etiology crosses your mind, next should be that whether this organism, this organism may be having some sort of a resistance. For that, you can look at the comorbidities, the history of recent use of antibiotics, etc., as well as the local resistance pattern. So all these things should come to your mind before considering prescription of an antibiotic. This also we did discuss. That is, when you are selecting an antibiotic, you need to look at these factors as well, not only the efficacy and safety, but the resistance prevalence as well as the chance of collateral damage, about which we did discuss in the previous session. So these are the 9 factors to be considered when you are selecting an antibiotic. One is obviously the spectrum of coverage. You should know which antibiotic will cover for gram-positive organisms, which antibiotics are having gram-negative coverage, which are the antibiotics which are having an additional anaerobic coverage, etc. Then the patterns or resistance you should be knowing. The evidence or track record for a specified infection you should be knowing. Then the concentration achieved in the serum, tissue, CSF, etc. you should be knowing. The allergy, toxicity, IV versus oral bioavailability, etc. you should be knowing. And certain drugs will be having the same bioavailability. That is, IV as well as oral bioavailability will be the same. For example, azithromycin, metronidazole, the quinolones, then linezolid, etc. So in such cases, the IV is probably not required if the patient is not really sick. Oral will be having the same bioavailability as IV antibiotics. For beta-lactams, it is not. The bioavailability is slightly lesser for the oral formulation compared to the IV formulation. Then looking at the adherence, some patients would like to have lesser number of tablets, etc. So all these factors need to be considered before selecting an antibiotic. So in the OPD setting, to increase the use of directed therapy for outpatients, we have to define the infection in 3 ways. One is anatomically, that is, if it is sinus or not, something like that. Then microbiologically, if you think it is a sinus infections, you have to see whether it is due to a virus like say rhinovirus or an influenza virus or a para-influenza virus, or you think it is bacterial, then it could be pneumococcus, H. influenza, Moraxilla, etc. That is how to define it microbiologically. And then the third is pathophysiologically. And the golden rule is that obtain cultures before starting antibiotics, but this is actually very difficult in the outpatient scenario, except in situations like say a carbon situation like that. In other situations, or in the case of a cystitis, in other situations, collecting cultures before starting antibiotics in the OPD scenario may not be feasible. Whenever possible, we should choose narrow spectrum antibiotics to decrease the risk of collateral damage and thereby selecting out of resistant organisms. And we should use antibiotics with high genetic threshold to development of resistance. So high genetic threshold to development of resistance means low resistance potential. Antibiotics like doxycycline, nitrofurantoin, etc. And this concept is actually mirrored in the WHO, this AWARE classification. So antibiotics with less resistance potential or antibiotics with high genetic threshold to development of resistance are included under the access category of antibiotics. And we should be avoiding 3rd generation cephalosporins and quinolones in the outpatient clinic if possible. So they should be used only if there is a definite indication for using this 3rd generation cephalosporin or quinolones, because they come under the vast category of antibiotics. So basically, everyone should be aware of this categorization. So that is what are the drugs which come under the access category? That is the penicillins, amoxicillin, clavulanic acid, ampicillin, that will come under this category. Doxycycline, cotrimoxazole, nitrofurantoin will come under this, metronidazole, clindamycin, etc. So whenever we are choosing an antibiotic, if suppose the patient requires an antibiotic, we need to choose it from the access category. And interestingly, if you look at any of the standard treatment guidelines for the OPD scenario, that is the usual symptoms that you are likely to encounter in the OPD setting. So drug of choice is obviously going to be from the access category. So none of the drugs to be used in the OPD setting are from the WASH category. So the drugs in the WASH category are going to be the quinolones, third generation cephalosporins, then macrolides, the glycopeptides, etc. So of these, the oral drugs will be the third generation cephalosporins, the quinolones, and the penem, that is the pharopenem. So in majority of the situations, we do have alternatives from the access categories. Now, if you think that you need to start cefixime or cephalosporin for a patient, there has to be a definite indication, because for majority of the situations in the outpatient, we do have replacement drugs from the access category. And mind you, azithromycin, that is the macrolide group, as well as the quinolone groups, belong to the WASH category of antibiotics. The only oral drug in the reserve category is linezolid. So that you should keep in mind. So all other drugs in the reserve category, usually we don't use for the outpatient setting, except to an extent linezolid. Then the risk factors, that is, now when you are seeing a patient, suppose the patient is having uncontrolled diabetes with, say, urinary tract infection, patient has received multiple courses of antibiotics recently, say within 90 days or so, has been hospitalized recently, there has been history of a family member with a multi-drug resistant infection, etc. So if such history is there, so when you are selecting the antibiotic, probably you should keep one thing in mind, that is the patient may also be having infection with a drug resistant organism. But having said that, basically in the OPD, we mean that the patient is clinically stable. If the patient is clinically stable, there is always a chance for us to send the culture, start on a low-end antibiotic, say an antibiotic from the access category. And once the cultures are back, suppose it is resistant to the antibiotic that we have started, we can escalate later on. So this golden hour applies only to patients with severe sepsis or septic shock. In all other settings, that is, we believe that the patient is stable in the OPD, then always you identify the syndrome, start on a narrow spectrum antibiotic, if possible send a culture. So this applies to patients who are likely to harbor a resistant organism. Now, I will take you through some common clinical scenarios in the OPD. So a 35-year-old woman who presents with 2 days history of burning on urination and notice some blood in her urine. So according to IDSA 2010 guidelines, which is the best possible option for empirical treatment. Okay, so here the first question we should be asking is what syndrome the patient is having. It is likely to be an infection because the patient is having dysuria as well as blood in urine. So and it is likely to be what syndrome the patient is having. It's likely to be cystitis. Whether it's a complicated cystitis or uncomplicated cystitis, we don't know much about that. And I will say it is an acute uncomplicated cystitis, one of the common scenarios where antibiotics are being prescribed. So as per 2010 guideline, what is the empirical treatment of choice for acute uncomplicated cystitis? Will you start ciprofloxacin, nitrofurantoin, ampicillin, or cefalexin? So basically, prior to this 2010 guidelines, the A1 recommendation for acute uncomplicated cystitis was fluoroquinolones and cotrimoxazole, and nitrofurantoin was having and fosfomycin were having a B1 recommendation. And if you're suspecting a pyelonephritis, usually in cystitis, there won't be any flank pain or high-grade fever. Suppose the same patient is having high-grade fever and flank pain with chills, etc., then patient is having pyelonephritis. Pyelonephritis, the A1 recommendation is for oral fluoroquinolones for 14 days. That used to be the recommendation prior to 2010. And cotrimoxazole can be used if it is susceptible. It is a gram-positive cocci which is growing on gram stain. You can consider amoxicillin clavulanic acid. So in 2010 guidelines, certain other aspects were also considered because it is in the first decade of the 21st century that antimicrobial resistance gathered that much attention. That is, IDSA came out with terms like the escape pathogens and all. And because of increasing antimicrobial resistance rates, the concept of collateral damage came. Collateral damage means, so our gut microbiota. So our gut microbe, the total amount of microbes in our body is around 10 to 100 times more than the human cells in the body. Actually, we are actually moving mass of microbes than human cells. And the microbial DNA is far more than the human DNA in the body. So a majority of these organisms are present in the gut, and that is referred to as the gut microbiota. So when we are taking antibiotics, especially the broad spectrum antibiotic, whatever antibiotic it be, so it actually sort of kills off all the susceptible organisms, and the resistant organism will become the dominant population. So that is referred to as selecting out of resistant organism, and this is referred to as collateral damage. So even if you are, say, for example, you are taking some drug for otitis media. So damage is not in the site of infection. Damage is occurring at your gut microbiota. The drug-resistant organisms will become the dominant population, and some of the organisms in their gut flora will become resistant. And this infection due to this resistant flora might occur in future. So that is the concept of collateral damage. So this concept garnered attention in the first half of the 21st century. And because of collateral damage, majority of the guidelines were changed, and the guidelines A1 recommendation were given to drugs with less chance of creating this collateral damage. So based on these concepts, 2010, the guidelines for treatment of acute uncomplicated cystitis were changed, and the drug of choice became nitrofurantoin 100 mg BD for 5 days. If cotrimoxazole is, when you are choosing cotrimoxazole, we should be sure that the resistance prevalence against cotrimoxazole should be less than 20%. That is the importance of having antibiograms as well as the susceptibility data. In your hospital or in your locality, if the resistance to cotrimoxazole for the UTI sample is less than 20%, this also has an A1 recommendation. That is a double strength 101 for 3 days. If you are choosing cotrimoxazole for the treatment of acute uncomplicated cystitis, you require only 3 days of treatment. Whereas if you are choosing nitrofurantoin, you require 5 days of treatment. Then the ciprofloxacin actually is very effective, but then because of collateral damage and resistance potential, it was downgraded to a B1 recommendation. So basically now all the guidelines post 2010 looks at these 4 factors before saying that a drug is a drug of choice for a particular infection syndrome. So efficacy, safety, the resistance potential, as well as collateral damage. If you look at the efficacy of the fluoroquinolones or beta-lactams in AUC, you can see that the efficacy is almost as good as nitrofurantoin or cotrimoxazole. But the problem with safety is also pretty good for fluoroquinolone. The issue is with regard to resistance prevalence and collateral damage. Whereas for nitrofurantoin, the resistance prevalence is less, collateral damage is less. But if you look at fluoroquinolones, the collateral damage potential is high as well as the resistance prevalence is high. And that is why the recommendation was sort of downgraded to B1 for the fluoroquinolones. So the answer to this question will be nitrofurantoin 100 mg BD for 5 days. Suppose the same patient is having fever and flank pain, then nitrofurantoin cannot be used, because nitrofurantoin is a drug which is having very good urinary concentration, but the serum concentration of nitrofurantoin is less. Patient is having fever and flank pain means the patient is having probably pyelonephritis. Okay, pyelonephritis is a systemic infection, so you need an antibiotic with very good concentration in the serum. So nitrofurantoin does not have that, does not achieve therapeutic concentration in the serum, which achieves therapeutic or supratherapeutic concentration in the urine. So in case of pyelonephritis, the drug of choice happens to be the quinolones. The current recommendation is 7 days. In 2000, prior to 2010, it was 14 days. Oral ciprofloxacin, 10 mg BD for 7 days with or without an initial 4 mg dose of intravenous ciprofloxacin is A1 recommendation. Quinolones can be considered for empirical treatment if the resistance against quinolones in the community is less than 10%. So this is with regard to acute uncomplicated cystitis. Now we'll go to the second common scenario we encounter in the OPDs. A 23-year-old presented with features suggestive acute maxillary rhino sinusitis of 2 days duration. So what is the appropriate treatment? So the patient presents to you with fever, so a facial pain, then say a purulent discharge from the nose, etc. So you make a diagnosis of an acute sinusitis, and based on the site of tenderness, you say it is a maxillary rhinosinusitis. So what is the appropriate treatment? So we know that sinusitis, if it is not viral, if it is bacterial, so we need to cover for pneumococcus. So is it the drug of choice amoxiclav, or is it levofloxacin, doxycycline, azithromycin, or none of them? We should know that. So this is an article from NEGM based on the IDS recommendations. So how to differentiate between acute bacterial versus viral rhinosinusitis? We should know this because now I believe that almost 90% of the doctors will prescribe an antibiotic in this situation. Okay, so the indications for antibiotics are clearly spelled out in this article from NEGM as well as in the IDSA guidelines or from any guideline. The indication for antibiotics in sinusitis, in acute sinusitis, is the presence of signs and symptoms for more than 10 days without improvement. That is, persistence of symptoms for 10 days without improvement. The second indication is the severity, which is assessed by the presence of fever more than 39 degrees, purulent nasal discharge, and facial pain for more than 3 days from the beginning. And third indication is double sickening. That is, the patient was initially better, and then by around 5th or 6th day, patient becomes bad again. And this is due to bacterial superinfection. So these are the 3 indications for giving antibiotics in sinusitis. Okay, so if we look at our patient had been symptomatic only for 2 days, and probably we can wait. So if you are selecting an antibiotic, suppose this patient has been having high-grade fever, say high-grade fever, then having purulent nasal discharge with facial pain for 4 days duration, probably this patient will merit treatment with antibiotics. Then you should ask these questions. Is it viral or bacterial? Since patient has been having high-grade fever, the purulent nasal discharge, facial pain for 4 days, it's likely to be bacterial. So if it is bacterial, then what are the likely organisms? You should know that it's likely to be pneumococcus, H. influenza, or moraxella. So then the drug of choice in such situations happens to be amoxicillin. So, and mind you, pay an attention to the dose of amoxicillin for sinusitis. It is 1 gram TID for 5 to 10 days. You need to give 1 gram amoxicillin TID for 5 to 10 days, not 500 milligrams. It's 1 gram of amoxicillin to take care of pneumococcus in sinusitis for 5 to 10 days. And an alternative will be using augmentin 625 TID for 5 to 10 days, or augmentin 1 gram BD for 5 to 10 days. So ideally, the drug of choice or the drug to be selected happens to be amoxicillin. What are the situations in which you need to consider amoxicillin clavulanic acid upfront? That is in situations where you are suspecting some sort of a resistance. Okay, that is in healthcare workers. So healthcare workers with sinusitis, according to the guidelines, it has to be augmented. Then patients with who are smokers, the areas where there is their high level resistance to amoxicillin, penicillin to this pneumococcus. And then in patients who are having, say, diabetes, immunocompromised, then age above 65, etc. So in all other situations, this patient is a young, healthy, immunocompetent patient. With if the patient is having, say, acute a bacterial sinusitis, the drug of choice will be amoxicillin 1 gram twice a day for 5 to 10 days. In case of penicillin allergy, you can choose, say, doxycycline or clindamycin, levofloxacin, moxifloxacin, etc. So if you have these 4 options, you have to choose the antibiotic from the access category, that is doxycycline or clindamycin. This is very, very important. The things you should know is that 90% of the viral upper respiratory tract infections have a component of sinusitis associated with it. So of which only 0.5 to 2% will progress to bacterial sinusitis. If we ask the students, the patient is having rhinitis and other features of sinusitis. So it is clear that it is a viral sinusitis. Then why are you starting an antibiotic? They will say that it is to prevent a bacterial infection from occurring. So antibiotics actually can't prevent a bacterial infection from occurring. So we should know that if there is a rhinitis, in all probability, the sinusitis is also due to that virus. So the commonest cause of sinusitis or the pathogen responsible for sinusitis is not pneumococcus or moraxella or H. influenza. It is actually rhinovirus, influenza virus, and parainfluenza virus. And only in around 0.5 to 2% cases, it may progress to bacterial sinusitis. And also the natural history of acute sinusitis in adults is favorable. There is an 85% reduction or resolution of symptoms within 7 to 15 days without antibiotics. Still, antibiotics are prescribed in 90%. So even though there is a slight symptomatic improvement in the antibiotic arm compared to the placebo arm, the number needed to treat to observe this difference is around 7 to 18 patients. Now we will go to the third case scenario. So under a situation where the antibiotics are usually prescribed, that is acute pharyngitis. A 20-year-old boy present with fever, sore throat, tender cervical lymph nodes of 3 days duration. There is no cough or rhinitis. The pharynx and tonsils are congested. So how will you treat this boy? So patient present fever, sore throat. So basically patient is having acute pharyngitis. So how will you treat this boy? So amoxicillin, cephalexin, azithromycin, penicillin, or clindamycin. So when you are dealing with pharyngitis, we should know one thing. There are only 3 bacterial pathogens which require antibiotic coverage with antibiotics as far as pharyngitis is concerned. And everyone is worried about gas organs, that is group A, Streptococcus, because of its association with rheumatic fever as well as post-streptococcal glomerular nephritis, and that is why for pharyngitis, when you diagnose a young person with pharyngitis, we are in a hurry to suspect this streptococcal pharyngitis and start antibiotics. Other 2 indications for antibiotics will be diphtheria and or gonococcal pharyngitis. Both of them are quite rare, and so our focus should be to identify patients with streptococcal pharyngitis. For that, a scoring system is there. Initially, it used to be termed as the Cendor score, and then there was an addition. That is, the age criteria was also brought in, and then it became the modified Cendor score or the Mac-Isaac score. So the basic aim is that we need to identify the streptococcal pharyngitis. So majority of the pharyngitis are viral pharyngitis, but then we should not miss out on streptococcal pharyngitis in a particular age group. So this score actually will help us in identifying patients who are likely to have streptococcal pharyngitis. So it is basically a scoring system. So you can see absence of cough is 1 point. If cough is present, it is more likely to be viral. So absence of cough, something which favors streptococcal pharyngitis. Then swollen, tender, anterior cervical nodes. So tender anterior cervical nodes gets 1 point. Posterior cervical nodes are enlarged means there's likely to be a viral etiology. Then presence of temperature more than 30 degrees Celsius gets 1 point, and tonsillar exudate get 1 point. Okay, these are the 4 features usually seen in streptococcal pharyngitis: temperature, tonsillar exudate, anterior swollen, tender anterior cervical nodes, excuse me, and the absence of cough. Then there is an age criteria. That is 3 to 14 years, it gets 1 point. 15 to 44 years, 0 point, and more than 45 years is gets minus 1 point. And based on the scoring system, you can see that if the score is 1, the chance of this gas pharyngitis is 5 to 10%, and the recommendation is do nothing. Okay, if the score is 2 or 3, the chance of the gas pharyngitis score of 3 is around 28 to 35%. Recommendation is to, if you have access to the streptococcal antigen test, do that or do a throat culture, and based on that you treat. The score is more than 4, start empirical antibiotics. So this is the situation. Suppose in your OPD you don't have access to this culture, so antigen testing you don't have access to that culture, then you calculate this score, and the score is more than 3, equal to 3 or more than 3, then you are justified in starting an antibiotic. So any case of pharyngitis, please do apply this score. This is very easy to follow this scoring system, and based on this scoring system, you decide whether the patient is having a bacterial or a viral pharyngitis, and if it is a bacterial pharyngitis, whether the patient is having streptococcal pharyngitis or not. So these are the clues, the clinical clues that you are are going to help you in differentiating between a viral pharyngitis and a streptococcal pharyngitis. The presence of conjunctivitis, presence of rhinitis, the presence of cough, presence of diarrhea, the hoarseness, inflammation of the oral mucosa, and to an extent, the rash are features of viral pharyngitis. Okay, so if these features are there, you can think away from a streptococcal pharyngitis. Whereas the presence of abdominal pain, abrupt onset of sore throat, the history of the streptococcal pharyngitis in the past, patchy exudates in the tonsil, purple spots on the roof of the mouth, the scarlatiniform rash, etc. favors streptococcal pharyngitis. So this is actually from the IDSA guideline. How should the diagnosis of streptococcal pharyngitis be established? Okay. So the swabbing of the throat and testing for streptococcal pharyngitis by rapid antigen test or culture should be performed because the clinical features alone do not reliably discriminate between streptococcal pharyngitis and viral pharyngitis, except when overt viral features like rhinorrhea, cough, oral ulcers, and hoarseness are present. So the bottom line is that if the patient with pharyngitis is having rhinorrhea, cough, oral ulcers, and with or without hoarseness, you can think away from streptococcal pharyngitis. So these are very easy things to follow in our OPD. Suppose it is a streptococcal pharyngitis. In our case, it is likely to be streptococcal pharyngitis. Then what will be the drug of choice? Streptococci is exclusively sensitive to penicillin. So if you do have access to this penicillin, so either Pentix or K-pen, so start the patient on penicillin and the streptococcus will respond beautifully to that. So dose of penicillin B, oral penicillin B will be 250 milligram, 6th hourly or 500 milligram BD. So in our case, it has to be given for 10 days because we need to ensure that the streptococci is eradicated from the throat. So give it for 10 days. So if you don't have access to this penicillin B, then start amoxicillin. The dose of amoxicillin for pneumococcus sinusitis was 1 gram TID. But for this, you don't require that much high dose, 500 milligram is enough, but give it for 10 days. For individuals with penicillin allergy, you can consider drugs like cephalexin, ceftriaxone, clindamycin. So these are drugs from the access category compared to the other options like azithromycin, clarithromycin from the vast category of antibiotics. So basically, any patient with streptococcal, any patient coming to you with acute pharyngitic syndrome, apply the score, apply the modified Sendor score, look for features which will help you in identifying a viral pharyngitis. And if you feel that it is a streptococcal pharyngitis, treat with penicillin V. The next usual scenario will be a 25-year-old presenting with fever, sore throat. That patient is having exudative pharyngitis with bilateral posterior cervical lymph nodes, a rash, hoarseness of voice. The labs are suggestive of leukopenia, lymphocytosis, and mild transaminitis. So these features, now we discuss in detail, these features are suggestive of a viral etiology. But the throat swab was taken, but it is growing group A streptococcus, that's gas infection. So all other features are favoring a viral etiology, but the throat swab is growing streptococcus. So should you treat the streptococci with amoxicillin, azithromycin, cefuroxime, or can it be a sort of a colonizer? So one thing we should know, in around 30% cases, streptococcus may be present normally in your throat. Okay, so it does not require treatment. So the streptococcal throat carriage and the carriage requires treatment only in certain situations, like so if there is an outbreak of, so there is a community outbreak of gas infection or outbreak of rheumatic fever or streptococcal glomerulonephritis, etc. So in this case, posterior cervical nodes, rash, hoarseness of voice, etc., is pointing towards a viral etiology and does not require any antibiotic. So these are certain clinical parts. Hoarseness is a feature of viral pharyngitis. Viral picture with posterior cervical nodes and transaminitis. Think about Epstein-Barr virus infection, cytomegalovirus infection, or HHV6. So this is very important. So usually the transaminitis, if you suppose the SGPT is slightly elevated, it is pointing towards a sore throat with transaminitis is pointing towards a viral etiology. Even, for example, one of the close DDs for diphtheria. So that is a membranous tonsillitis is Epstein-Barr viruses. IMN can also have this membranous tonsillitis. Usually in diphtheria, the transaminitis may not be there, whereas in IMN, transaminitis may be there. So in case of a pharyngitis with transaminitis, think about a viral etiology. Bullous laryngitis with non-exudative pharyngitis, etiology could be mycoplasma. And you know the treatment of mycoplasma is going to be drugs with atypical coverage, like say doxycycline or azithromycin or clarithromycin. So non-exudative pharyngitis with laryngitis, think about chlamydia pneumonia, and the response to the doxycycline or azithromycin is going to be very rapid. A membranous pharyngitis with rash is actually, there is a membranous pharyngitis, it's a diphtheria like pharyngitis with rash is due to Actinobacterium hemolyticum or Corynebacterium hemolyticum. So this is one clinical clue which will help you in identifying infectious mononucleosis. One of our patients, you can see that bilateral upper lid painless edema without conjunctival congestion. You can see that this boy is having painless bilateral upper lid edema is there. There is no conjunctival congestion, no tenderness. This is referred to as Hoagland sign. Hoagland sign is classically seen in infectious mononucleosis. So boy is having this pharyngitis with this sign. This is seen in the first week. Okay, by around third or fourth day, you can diagnose it as IMN, because in the IMN, the monospore test will take weeks to become positive. And usually the more sensitive tests like the EBV, viral capsid antigen, etc., also may take around 2 weeks. So in the first week to diagnose IMN, if you don't have access to EBV PCR, these signs can help you. Seen in around 20% of the patients with IMN. The next scenario is going to be a 14-year-old male with fever, sore throat, rhinitis, and cough of 2 days duration. No comorbidities. What is the optimal treatment? So this is a situation which it's one of the very common situations. So what is this? Fever, sore throat, rhinitis, and cough. So it is basically an influenza-like illness, right? So ILI syndrome, you can say an ILI syndrome. And since rhinitis is there, it is likely to be viral etiology. So now what virus? Is it a rhinovirus? Is it influenza? Influenza means it could be H1N1 or H3N2 or influenza B. Could it be COVID-19? Lot of possibilities are there. Here, so the first thing is, what is the infection syndrome? It is likely to be an influenza-like illness. So what is the likely etiology? It is likely to be viral etiology. So which virus? Lot of viruses. Could be rhinovirus, para-influenza virus, which could be H1N1 or H3N2, or it could be COVID-19 as well. So the patient, this is a 14-year-old without any comorbidities, so clinically stable patient. So what will be the optimal treatment in this case? So basically, it is going to be observation only. Watch for red flag signs. So this, everyone will be knowing this categorization of A, B, C. That is for influenza. Actually, we have adopted this categorization for COVID-19 also, so that the ground staff will be familiar. They are already familiar with the influenza categorization. So the category says that the patient is having a mild fever, as in this case, it is a category A. That is an influenza. Mild fever is category A. So does not require testing and does not require Russell timer. So what this patient requests is actually the close observation for development of red flag signs, not antibiotics. But if you put this question to any of the students, they're likely to say that start the patient on some antibiotic, because they think that no one will think about a viral etiology. This is going to be a problem. Because suppose it is not a 14-year-old. Suppose that it is around, say, a 40-year-old patient with uncontrolled diabetes presenting like this, and the doctor is writing, thinking that it is bacterial and writing, so levofloxacin. Suppose it turns out to be H1N1 or COVID-19, what could be the outcome? So now we are all worried about COVID-19, so definitely this patient will get tested for COVID-19. But what about influenza? So this is the importance. No, the viruses can be real killers in patients who are immunocompromised. Now, this is one situation that we have been going through for the last 2 years or so. So we know that initially our treatment protocol did include azithromycin for treatment of COVID-19, but it was not included as an antibiotic. It was included as an immunomodulators. When we had enough and more studies saying that azithromycin is not useful in the treatment of COVID-19, it was taken away from the state guidelines as well, and it is one of the rare guidelines where it is written azithromycin should not be used for the treatment of COVID-19. Why? So still you can see that anyone being diagnosed with COVID-19 is likely to get a prescription of azithromycin. So majority of the doctors are prescribing azithromycin. If you ask them, if we tell them that azithromycin do not have any role in preventing the progression of COVID-19, then they will say that, what is the harm in giving azithromycin? So it will cause only gastritis, or the QT prolongation is very rare. So what is the harm in giving 5 days of azithromycin? So this is the question that usually the doctors will ask us back. And that is the importance of knowing the concept of collateral damage. The use of azithromycin will lead to the genesis of macrolide resistance in pneumococcus. It's very, very important. So if you are using right and left azithromycin for COVID-19, the prevalence of macrolide resistant pneumococcus in our state is going to go up a lot. So this study was published from Manipal, was published in 2010. At that time, the erythromycin resistance in macrolides was around 14%. Okay, so the previous studies published from the rest of the world, Malaysia, etc., the prevalence of resistance to the macular resistance pneumococcus was as high as around 50%. So recent studies have shown that the macular resistance in India also have gone up to around say 30%, 30 to 40%. So, and we have studies from Finland, etc., showing that the prevalence of macular resistance in pneumococcus is directly proportional to the use of macrolides in the community. So a rampant misuse of azithromycin is going on for COVID-19, and it is likely to drive up the resistance, macular resistance in pneumococcus in the state. So it's very, very important. That is why we say that it's not about empiricism. That is what actually pains us a lot. So the influenza-like illness means that the doctor can always say that we are not testing for influenza. We don't know the diagnosis. Could it be bacterial? Can it be an atypical? So that is why we are using azithromycin. But COVID-19, there are no excuses. No, it is not about empiricism. You know the diagnosis. You know it is COVID-19. You know it is viral. Then why are you using azithromycin? Because you don't know the concept of collateral damage. It's being used because majority do not know the concept of collateral damage. Majority do not know that the use of macrolide can hike up the resistance to macrolides among pneumococcus. So this is a study that everyone of us should be aware of. The next case scenario will be a 25-year-old presenting with skin and soft tissue infection. What is the appropriate antibiotic choice? So usually we know that the skin and soft tissue infections are divided into two. There is the purulent as well as apurulent. So there are two entry points, and you can say that it is the purulent infection. So purulent infection means it is likely to be due to Staphylococcus aureus. Okay. Usually the common organisms, if the patient is immunocompetent, the common organisms are Streptococcus, which usually lead to lymphangitis or cellulitis like presentation. You won't be having this point of entry or the pus like this, or a presentation like this. It's a pharyngeal or carbuncle or abscess like presentation. There will be a point of entry with pus that is due to Staphylococcus aureus. Okay, and this patient do not have any risk factors for MRSA. We assume that. So probably this patient is having methicillin susceptible Staph aureus infection. So what is the drug of choice for methicillin susceptible Staph aureus infection? It is cloxacillin. Okay, but then does cloxacillin have very good bioavailability? So the bioavailability of cloxacillin is not very high. So the second choice will be cephalexin. So either cephalexin is also an access category antibiotic. Cephalexin is a first generation cephalosporin. So you can choose between cloxacillin or cephalexin. So if you have access to clox and a patient can tolerate it, use cloxacillin, or else you use cephalexin. So this is the IDSA guideline. All cases of SSTIs, you see whether it is a purulent SSTI or a non-purulent SSTI. If it is a purulent SSTI, it is due to Staphylococcus aureus. It could be MSSA or MRSA, usually abscess, carbuncle, or pharyngeal. Then see whether it is a mild infection, moderate, or severe infection. So if it is just an abscess which is mild and less than say 2.5 centimeters or so without that much of induration or edema, so you can just do an IND, no need for antibiotics. It is moderate, do an IND and send for culture and sensitivity, and empirically start the patient on cotrimoxazole or doxycycline, because now if you're not sure whether it is MSSA or MRSA, then choose a drug which will cover for both MSSA as well as MRSA. That is, cotrimoxazole, doxycycline, clindamycin can cover for both. And then suppose the culture is growing MSSA, you can say de-escalate to cloxacillin or cephalexin. If it is a severe infection, definitely IND and cultural sensitivity, and you require IV antibiotics, initially which will cover for both MSSA as well as MRSA, and then optimize based on the cultural sensitivity report. Whereas in case of a non-purulent cellulitis, non-purulent SSTI, could be cellulitis or necrotizing infection or erysipelas, then it is streptococcus. For streptococcus, you need to, the drug of choice, as we have discussed, is going to be the penicillin V or cephalosporin. So it is a mild. It is moderate, then you use penicillin, that is intravenous penicillin. Now it is severe, obviously you go for vancomycin plus piracetam. But then suppose the patient is a diabetic or an immunocompromised. It need not be, say, infection due to Staph aureus or streptococcus. It could be polymicrobial as well. So in such situations, you need to select antibiotics which will cover for Pseudomonas as well, especially in diabetic patients. Then another common situation where the antibiotics are being prescribed, that is a 25-year-old with history of influenza-like illness, category B1, presented with persisting cough, mucopurulent sputum, foreign body sensation not subsiding even after 3 weeks, no fever or chest signs. So it's a very common thing. That is, the patient had a influenza-like illness, and the cough is persisting. So persisting cough, it could be a dry cough, or it could be a mucopurulent sputum production. Patient won't be having any fever. They will be saying that no, after say talking, they will have a bout of cough-like thing. So this is referred to as this upper airway cough syndrome. The patient is not having fever, is not toxic, no chest signs. It's referred to as upper airway cough syndrome. It's a sort of bronchitis-like thing. So how will you treat this patient? Azithromycin, montelukast with levocetirizine, the Avil with cough lozenges, short course steroids, sputum culture, Uti, etc. So ideally, they say that for the treatment of upper airway cough syndrome, which is actually due to a sort of a irritation in the throat, we need to use antihistamines with anticholinergic properties. And the antihistamine with anticholinergic property is our Avil, that is Feniramine maleate. So levocetirizine, etc., won't be having that. So in this patient, since the patient is clinically stable and we are not getting a sign of infection per se, so start the patient on Avil with cough lozenges, that is the soothing agents. Okay, and then if there is no improvement, then try ipratropine nebulization because of its anticholinergic activity. Still there is no improvement, go for short course of steroids. Okay, the sputum is yellow does not mean that it is having infection. So yellow could be due to a lot of reasons. Okay, so in this situation, it's a situation which we commonly encounter, treat the patient with Avil plus cough lozenges, no improvement, go for ipratropine inhalation. Still no improvement, go for short course of steroids. Then another common situation, a 32-year-old man presents to the OPD with complaints of loose watery stools since after midnight, no blood or mucus in stools, 2 episodes of fever, and history of outside food taken at lunch. That is, after taking food from outside, around say 12 hours later, the patient is developing loose watery stools. Okay, on examination, no dehydration, abdomen is soft. What will you start? Okay, will you start ciprofloxacin, azithromycin, metronidazole? None of them. So what syndrome are we dealing with here? The patient is having say acute watery diarrhea, and this occurred say 12 hours after taking food from outside. So these are the questions that should come to our mind when we are approaching a case of diarrhea. So is it an acute diarrhea or is it a chronic diarrhea? So in this case, it is an acute diarrhea. Is it watery or a bloody diarrhea? So bloody diarrhea means the organisms are likely to be Salmonella, Shigella, etc. And probably the patient might require antibiotics. So in this case, it is a watery diarrhea. The next is the host factors. Is it immunocompetent host or an immunocompromised host? So immunocompromised means probably we may have to err on the side of antibiotics. The fourth is the clinical status. So is dehydration present or red flag signs present? Then fifth is the presence of the signs of sepsis or SIRS, etc. Then probably that in such case also antibiotics may be warranted. Then in any case of diarrhea, we need to look at the clinical demographic as well as epidemiological factors. That is like, say, suppose an entire family went to have food from outside, everyone is having diarrhea like that. So we need to look at the epidemiological factors. So in this case, the patient is having an acute watery diarrhea. It's an immunocompetent host. There is no dehydration, no red flag signs, no evidence of sepsis. So the epidemiological factors, we don't know what happened to the other persons who took food from the same restaurant. We don't know that. Then when we assess the clinical factors, the most important thing will be exposure history. We know that the patient took food from outside. Second is the incubation period. That is, at what time after taking food from outside did the patient develop diarrhea? So basically, he developed it after 12 hours. So we know that foodborne pathogens based on the incubation period, we have a sort of an idea. That is, Staph aureus, there is Staph aureus can lead to the symptoms within say 6 hours of intake of a particular type of foods, etc. It is between 8 to 16 hours. It could be due to the Bacillus cereus, or it could be Clostridium perfringens or norovirus, etc. So in this case, it's likely to be a viral diarrhea. So it is very, very important. Then the type of food consumed is based on the patient has taken pork or say poultry or eggs or the egg products, this milk products, etc. From that also you have a clinical clue towards the probable etiology and whether antibiotics are required. So these are the common organisms, so situations where antibiotics might be required in case of diarrhea. That is, if you're suspecting Salmonella, Shigella, Campylobacter, Vibrio, Yersinia, Clostridium difficile. So as per the IDSA 2017 recommendations in immunocompetent children and adults, empirical antimicrobial therapy for bloody diarrhea while waiting for research or investigation is not recommended, except in the following situations. Even for bloody diarrhea, so the starting antibiotics empirically recommended only in certain situations, that is in infants less than 3 months of age with suspicion of bacterial etiology. Then in immunocompetent people with fever documented in a medical setting, abdominal pain, bloody diarrhea, and features of bacillary dysentery, that is the scanty blood stools, fever, abdominal cramps, etc. Because the etiology is likely to Shigella, start the patient antibiotics. Or in a patient with history of travel, international travel with a body temperature more than 38.5, with or without signs of sepsis. So these are the only indications for empirical initiation of antibiotics, even in a setting of bloody diarrhea. Then I think this is the last case. A 44-year-old lady undergoes executive checkup. So this is a common situation. This the patient is is totally asymptomatic, then decides for an executive checkup. The urine is showing 15 pulses per high power field. So what would you do next? So the patient is totally asymptomatic, 15 pulses. That is asymptomatic pyuria. This patient is having asymptomatic pyuria. So asymptomatic pyuria. So should you ask for an urine culture? Should you go for empirical nitrofurantoin? If the culture is sterile, will you go for cystoscopy or reassure the patient? We know that in around say 14% of females, you can have asymptomatic pyuria. In around 2.5% of males also can have asymptomatic pyuria. So if there are no other features of infection, like say a persistent fever or a features of urethritis or cystitis or any vaginal discharge or any history of weight loss, etc., then this asymptomatic pyuria need not be investigated further. But then since for females, because of leukorrhea, etc., also you can have pulses. You take a detailed history. Okay, so clinically, there are no other pointers towards any infection. This asymptomatic pyuria in around 14% of females can be taken as normal and do not require any further investigation. Suppose it is an asymptomatic bacteriuria. So patient is not having any features of infection, but then the culture is growing, say E. coli. Then asymptomatic bacteriuria should be treated only in say 3 situations. One is the patient is pregnant. Definitely it has to be treated. The second is if you are planning an endourological procedure, because now endourological procedure, urological interventions means the mucosa is likely to be breached. So in such situations also the asymptomatic bacteriuria should be treated. And then post-transplant patients also asymptomatic bacteriuria should be treated. In other situations, asymptomatic bacteriuria need not be treated. So the question is, so we have discussed about the common situations where you can practice antibiotic stewardship in the OPD. So we have discussed that now there are so many situations. Then where should we be focusing? So this is an article which came in SIDS. They said that and they looked at the antibiotic courses prescribed and prescriptions per provider in 2011. The maximum prescription was from dentistry. So when we are planning antimicrobial prescription, antimicrobial stewardship, you need to focus on areas like say dentistry, etc., because there also antibiotics are being prescribed right and left. So this actually I did show this the graph on day 1, but since we are dealing with an OPD antimicrobial prescription, I will take you through this graph once again. So this study was done looking at around 12,000 prescriptions from the OPD of Trivandrum Medical College. You can see that the prescriptions were maximum from ENT, dermatology, general surgery, and general medicine. So when you are planning an antimicrobial stewardship plan in the OPD, you need to know the departments where the maximally antibiotics are getting prescribed. It need not be in medicine, pediatrics, or surgery. You need to look at the other departments like dermatology, ENT, etc. Then we have the WHO target of using say 60% of antibiotics by 2023 should be from the access category. And our study showed that in the OPD, 60% of antibiotics were from the access category, 37% were from the watch category, and 2% from the reserve category, that is Linus solid use. So the thing is that what WHO has said is that the total antibiotic prescription, that is OPD plus IPD plus ICU, 60% should be from the access category. Means that in the IPD and ICU, especially in the ICU, we have limitations. You can't treat the patients in the ICU with access antibiotics. This will result in mortality of the patients that we know because of the increased prevalence of ESPL, Pyramidase producing Enterobacteriaceae, etc. So definitely we will end up using antibiotics from the reserve category in patients in the ICU. So if you want to achieve the WHO target of 60% use of antibiotics totally in a hospital to be from the access category, definitely we have to focus on the OPD setting. In the OPD setting, as we have discussed, around 99% of the common infectious syndromes in the OPD presenting to you can be covered by antibiotics from the access category. Only if you do that, we'll be able to achieve the WHO target of 60%. We cannot, use access antibiotics in the ICU without culture. Now, looking at the watch group antibiotic utilization, the commonest the antibiotics from the watch group which are prescribed in the OPD are azithromycin, cefprioxime, ciprofloxacin, cefixime. I think you have understood that all these antibiotics do have replacement or substitutes from the access category for the infection syndrome that it is supposed to cover. These are the situations where cefprioxime was used in the OPD for cellulitis. You could have seen that the IDS chart, cefprioxime is not at all mentioned in the treatment of cellulitis. Sinusitis, no one has said that cefprioxime should be used for sinusitis. Abscess, LRTI, non-healing ulcer, CSOM, post-surgery, ASOM, pharyngitis, etc. So you can see that in all these situations, you have substitutes from the access category. So we have a big opportunity in the OPD, because OPD we are dealing with the stable patients. So now we are, even if we get it wrong, there is always an opportunity for us to correct it later. The same cannot be applied to a patient who has come to you in the casualty in septic shock like that. There you have to get it right within 1 hour. The same logic does not apply to the patients who are coming to you in the OPD. Then the antibiotic use pattern for upper respiratory tract infections. You can see that the watch category is getting prescribed in 41%, access in 58.5%. You know that the watch category getting prescribed is azithromycin. In India, it is better to use doxycycline instead of azithromycin for obvious reasons, because strep can also present like community acute pneumonia. In select locales, even melioidosis can present like community acute pneumonia. So ideally, azithromycin should be replaced with doxycycline in India for community acute pneumonia. So this we'll discuss later. Usually we say that we should give antibiotics for a very short period of time. There are certain exceptions. So the last three is very important as far as the OPD scenario is concerned. For a streptococcal sore throat infection, 7 to 10 days of antibiotics is necessary. Ideally 10 days, 3 to 5 days is in period can lead to recurrence of infection or relapse of infection. Otitis media also, 10 days of antibiotic is required if it is a purulent otitis media. Then why this is important? What is association between outpatient antibiotic prescribing practices and community associated C. diff infection? Fortunately, even though we are having hospital acquired C. diff in our state, we don't have community acquired C. diff as of now. So this study is from USA, which shows that 32% of Clostridium difficile infection are community acquired. Reducing antibiotic prescription rates by 10% among persons more than 20 years old was associated with a 17% decrease in C. diff infection. So to conclude, the therapeutic benefit of antibiotics should be balanced with their unintended adverse consequences. Inappropriate antibiotic use is associated with increased antibiotic resistance, adverse drug effects, and even infections like C. diff. Antibiotic stewardship is important for preserving antibiotics and improving patient outcomes. Antibiotic prescribing should be prudent, thoughtful, and rational. So many people think that antibiotic stewardship can never be practiced. It's not so. Everyone can practice antibiotic stewardship. to begin with, you may not be able to practice to the utmost extent, like what we have been discussing over the last 3 days or so. But like what Thailand has done, that is the Antibiotic Smart Country Initiative, they focused on 3 infections. That is the acute respiratory infection, then diarrheal disease, and then then the wound infection. So to practice antibiotic stewardship, if you're working in a small hospital or a PHC, there also you can look at the percentage of antibiotics that you are using from the access category, watch category. Set a target for yourself and see after 1 year. So focus on, say, upper respiratory tract infection. So if you're asking for symptoms suggest a viral, and what all situations you can avoid using antibiotics. The thing is that one feedback I have received from the PHCs, that the patient will be in the queue for, say, 4 hours to see the doctor, and then the doctor is prescribing paracetamol and cetirizine. We might lose the patient to our system. So that is one common feedback that we get from the PHCs. So how the developed nations tackle is actually by patient education. So they will actually educate the patient about this is actually a viral sinusitis. They won't use the term sinusitis. It is viral sinusitis, viral pharyngitis, etc. And then they will say that antibiotics are not required, and if antibiotics are used, there is a chance of resistance. But our problem is that we have a study saying that in our PHCs you get only 2 minutes to talk to the patient. So we can't spend that much time in patient education. So instead, what can be done is that we should focus on non-antibiotic treatments. For example, acute bronchitis, if you look at the CDC, there is a toolkit. Say that acute bronchitis do not require any antibiotics, but they say that patient should be advised regarding using steam inhalation. Then if it is pharyngitis, using NSAIDs like that. So it's not that we are not giving any medicines. We are giving supportive medicines to alleviate the patient of the symptoms. So that is actually very, very important. In any setting, we'll be able to practice antibiotic stewardship in our own way. So thank you very much for patient listening.
Is antibiotic stewardship applicable for topical ophthalmic agents?
Actually, it's a very interesting question because in ophthalmology and antibiotic drops are being used, as well as anti-viral as well as antifungal drops are being used in ophthalmology. And I am really not aware of any initiative about antibiotic stewardship with regard to this ophthalmic ointment, etc. Maybe because the chance of collateral damage is less, because systemic absorption may not be that much. So anyway, I will look into it.
upon ophthalmology നമ്മൾ പറയുമ്പോഴത്തേക്കിന് സിപ്രിഫ്ലോക്സാസിൻ ഡ്രോപ്സ് മോക്സിഫ്ലോക്സാസിന് അങ്ങനെയുള്ള ഫ്ലോണോക്ലോൺ ആന്റിബയോട്ടിക്സ് കൂടുതലായിട്ട് നമ്മൾ യൂസ് ചെയ്യുന്നുണ്ട് കൂടാതെ ടോബ്രമൈസിന്.
അതെ മാഡം, ആക്ച്വലി അതിന്റെ ആന്റിബയോട്ടിക് സ്റ്റുവാർഷിപ്പിനെ പറ്റി ഗൈഡ് ലൈൻസ് ഒന്നും ഇല്ല. അത് വരാത്തതിന്റെ ഒരു റീസൺ പ്രോബബ്ലി ഇതായിരിക്കും. കാരണം ഇത് ഒരിക്കലും ഗട്ട് മൈക്രോബയോട്ടയിൽ ഒരു കൊളാറ്ററൽ ഡാമേജ് ഒന്നും ഉണ്ടാക്കത്തില്ല ഡ്രോപ്സ്. But still local level
resistance ഉണ്ടാക്കാൻ ചാൻസ് ഉണ്ട്. കാരണം നമ്മൾ ഒരു പേഷ്യന്റ് നമ്മുടെ ഹോസ്പിറ്റലിൽ വരുമ്പോൾ തന്നെ ഓൾറെഡി they have on ciprofloxacin or some other fluoroquinolone antibiotics from the baseline itself. So
അതെ മാഡം, ഈ ആസ്പെക്ടിനെ പറ്റി ഒന്ന് ആക്ച്വലി പഠിക്കണം. ഒന്ന് നമുക്ക് ഈ ഏരിയയിൽ നമ്മൾ സെൻസിറ്റിവിറ്റി ഒന്ന് നോക്കിയിട്ടല്ല കൊടുക്കുന്നത്, അല്ലേ മാഡം?
എംപിരിക്കൽ ആയിട്ട് ഓൾറെഡി പേഷ്യന്റ് ആണ്, ഒരു PHC ഒന്നും അല്ല. ഞാൻ ഡിസ്ട്രിക്ട് ഹോസ്പിറ്റലിൽ വർക്ക് ചെയ്യുന്നതാണ്, സീനിയർ കൺസൾട്ടന്റ് ഓഫ്താൽമോളജി. അപ്പൊ ആണെങ്കിൽ പെരിഫറി എന്ന് വരുമ്പോൾ തന്നെ ഓൾറെഡി ഒരു ആന്റിബയോട്ടിക് കഴിഞ്ഞിട്ടായിരിക്കും നമ്മുടെ അടുത്ത് വരിക. അപ്പൊ നമുക്ക് റെസിസ്റ്റൻസ് ആണ്.
അതെ മാഡം, അപ്പൊ അത് മീൻസ് യൂഷ്വലി നമ്മൾ ഈ ആന്റിമൈക്രോബിയൽ സ്റ്റുവാർഷിപ്പ് പറയുമ്പോൾ നമ്മുടെ ഒരു വെപ്പൺ എന്ന് പറയുന്നത് ആന്റിമൈക്രോബിയൽ സസെപ്റ്റിബിലിറ്റി ഡേറ്റ വെച്ചാണ് ഇതെല്ലാം പറയുന്നത്. ഒപ്താൽമോളജിയിൽ അതില്ല എന്നതാണ് നമ്മുടെ ഒരു പ്രോബ്ലം. എനിവേ മാഡം, ഇതിനെപ്പറ്റി ഐ വിൽ റീഡ് അബൌട്ട് ഇറ്റ്. It's actually a new field. Definitely, as madam said, it will lead to local resistance.
Sir, sometimes patient demands the antibiotic even if there is a history of even if there is a single day history of fever. That's a very common question.
Actually, adana nammade means the concept of antibiotic literacy or antibiotic saksharata ennu parayunnathu to educate the public also. If you go through the CDC site etc., they clearly explains what are the harms if you take antibiotic. ഇപ്പം നമുക്ക് ഒരു PHC ഇരിക്കുമ്പോൾ ഒരിക്കലും ഒരു സ്റ്റിറോയിഡ് ചുമ്മാ എഴുതാൻ പറ്റത്തില്ല, അല്ലെ? കേരളത്തിലെ സ്റ്റിറോയിഡ് എഴുതി കഴിഞ്ഞാൽ അപ്പോഴ് ആൾക്കാർ ചോദിക്കും, ഡോക്ടറെ സ്റ്റിറോയിഡ് വേണോ, എന്തിനാ സ്റ്റിറോയിഡ് എഴുതിയെന്ന് ചോദിക്കുകയാണ്. സ്റ്റിറോയിഡിനെ പറ്റി ഒരു പെർസെപ്ഷൻ ഉണ്ട്. അതേസമയം ദേ ആർ നോട്ട് റിയലി അവെയർ ഓഫ് ദ ആന്റിബയോട്ടിക്സ് കൊണ്ട് ഫ്യൂച്ചറിൽ ഉണ്ടാകാൻ ചാൻസ് ഉള്ള പ്രോബ്ലംസോ റെസിസ്റ്റൻസോ ഒന്നും അറിയത്തില്ല. നമ്മൾ ഇനിഷ്യേറ്റ് ചെയ്ത ഉദ്ദേശം തന്നെ അത് തന്നെയാണ്. അതായത് in future, maybe after 3 or 4 years, if you write an antibiotic, the patient should ask, why did you write this antibiotic? That is our ultimate aim. Okay, if the doctors are not practicing antibiotic stewardship in 2 or 3 years, the patients will start asking this question, why did you use this antibiotic? We know that in majority of the developed nations, even paracetamol is not being prescribed if the fever is less than 101. This is not needed. Antibiotics are not prescribed at all. There patients are not dying. But patient education is a problem. They are demanding antibiotics. Then they can go to the pharmacy. If you are not prescribing an antibiotic, they can go to the pharmacy and get an antibiotic. But അതുകൊണ്ടാണ് ഈ pharmacist educate ചെയ്യുന്നത്. അല്ലാതെ നമ്മൾ മാത്രം വിചാരിച്ചാൽ ഇത് നടക്കത്തില്ല. We have to educate the public. We have to educate the pharmacist. That is, if the patient is going to the pharmacy for purchasing an antibiotic over the counter, there the pharmacist will educate them. Without doctor's prescription, you should not be taking an antibiotic like that. So it's a very complex issue. We have to, everyone has to be in it together. Public awareness ചെയ്യുന്നുണ്ട്. സ്റ്റുഡൻസിനെ right from the school period onwards, we are trying to get it into their curriculum also. അതായത് ഈ viral infections, നേരത്തെ നമ്മൾ അത് CDC ക്ലിയർ ആയിട്ട് പറഞ്ഞല്ലോ, ഈ infections are due to viruses, bacteria, etc. These antibiotics are going to work only against bacteria. So virusne against work ചെയ്യത്തില്ല. 90% infections, or in certain situation 99% infections are due to viruses. അതിനേരെ ആന്റിബയോട്ടിക് കൊടുത്തു കഴിഞ്ഞാൽ അതിനുള്ള അഡ്വേഴ്സ് ഇവന്റ്സ് മാത്രമേ ഉണ്ടാവത്തുള്ളൂ എന്ന് പറഞ്ഞ് മനസ്സിലാക്കുക. അഡ്വേഴ്സ് ഇവന്റ് എന്ന് പറയുമ്പോൾ നമ്മൾ ഈ ചൊറിച്ചിലോ അല്ലെങ്കിൽ ഗ്യാസ്ട്രൈറ്റിസോ ഒന്നും അല്ല പറയേണ്ടത്, ഫ്യൂച്ചർ റെസിസ്റ്റൻസ് തന്നെയാണ് ആക്ച്വലി പറയേണ്ടത്. സോ ഇറ്റ്സ് എ വെരി സ്ലോ പ്രോസസ് ആൻഡ് ഐ തിങ്ക് means if you are in it together, probably we will be able to achieve it.
Some doctors are prescribing amoxiclav in BD dose. Is it bactericidal in this dose?
625 BD എന്ന് പറയുന്ന ഡോസ് കാര്യമില്ല കേട്ടോ. എന്ന് വെച്ചാൽ ക്ലൗലാനിക് ആസിഡ് ആക്ച്വലി cannot lead to the extending the duration of amoxicillin. 625 has to be given TID. If you are using 1 gram, it can be given as BD.
Sir, how to differentiate mild, moderate, and severe infection in SSTI?
Mild, moderate, and severe infection എന്ന് പറഞ്ഞാൽ suppose it is just ഒരു pharyngeal ഒരു abscess which is less than 2 centimeters without any surrounding edema, not much of pain, you will take it as a mild SSTI. So moderate SSTI means there won't be any signs of SIRS-ന്റെ ഒന്നും കാണത്തില്ല, അതായത് tachycardia കാണത്തില്ല, systolic BP, everything will be normal. അങ്ങനെ. So moderate with evidence of SIRS will be a severe SSTI.
Asymptomatic bacteriuria in diabetes needs treatment or not?
Actually, the IDSA guidelines clearly says that asymptomatic bacteriuria in diabetes do not require treatment. Asymptomatic bacteriuria requires treatment only in 3 situations. One is in pregnancy. Second is if you are planning an endourological procedure because the mucosa is going to be breached. Third is in a post-transplant situation. If you are going to treat this thing, suppose asymptomatic bacteriuria in diabetes, the problem is that the E. coli is going to become resistant to the drug that you are going to use. So in diabetes, it is not really advised. If there is evidence of infection, treat according to culture and sensitivity.
Antibiotic prophylaxis and UTI, any indications?
Actually, the only proven benefit for antibiotic prophylaxis is in what you refer to as the post-coital UTI. So in such situations, antibiotic prophylaxis will help. In certain situations, like say recurrent urinary tract infection or recurrent cystitis and diabetes, also it is being tried, even though there is not much evidence for the same.
Sir, in antenatal patients with UTI, if culture sensitivity is sterile but urine routine shows numerous pus cells and patient is symptomatic, whether to treat them or not?
Actually asymptomatic bacteriuria ട്രീറ്റ് ചെയ്യണമെന്ന് തന്നെയാണ്. പക്ഷെ അതിൻ്റെ അകത്ത് ഈ കൾച്ചർ എടുക്കുന്ന മുമ്പ് ആന്റിബയോട്ടിക് കിട്ടിയിട്ടുണ്ടോ എന്നുള്ള കാര്യങ്ങളൊക്കെ നോക്കണം. പിന്നെ വേറെ ലോക്കൽ തിങ്സ് ലൈക്ക് ലുക്കോറിയ അങ്ങനത്തെ എന്തെങ്കിലുമൊക്കെ ഉണ്ടോ എന്നൊക്കെ നോക്കണം. അല്ല, അസിംപ്റ്റമാറ്റിക് ബാക്ടീരിയൂറിയ ഹാസ് ടു ബി ട്രീറ്റഡ്, നോട്ട് അസിംപ്റ്റമാറ്റിക് പയൂറിയ. കാരണം ദിസ് പസ് മീൻസ് ഇറ്റ് നീഡ് നോട്ട് ബി ഇൻഫെക്ഷൻ പെർ സെ, ഇറ്റ് കുഡ് ബി ഇൻഫ്ലമേഷൻ ഓൾസോ.
സാർ, ന്യൂട്രോപിനിയ പേഷ്യൻസ് ഉണ്ടല്ലോ സാർ, കീമോതെറാപ്പിയിൽ നാഡിർ ഡേയ്സിൽ കൗണ്ട് ഡ്രോപ്പ് ആയിട്ട് വരുന്ന പേഷ്യൻസിന് actually usually what we do is we prescribe quinolones for preventing any big infection. നമ്മൾ ആ നാഡറിന് താഴെ പോയാൽ ഉടനെ തന്നെ നാഡർ ഡേയിൽ നമ്മൾക്ക് ഒരു എന്താണ് ANC ലോ ആണെന്ന് കാണുമ്പോൾ തന്നെ we prescribe quinolones. Is it really recommended or should we really watch for the
recommendation? Actually, no, it is not really recommended. It's recommended only if the ANC is less than 100. Okay, but the thing is that if you're not very sure about the infection control practice, etc., to be on the safe side, you are prescribing it. And one thing we should keep in mind, antimicrobial stewardship is not about decreasing the use of antibiotic. It is about optimizing the outcomes of patients. So when we talk about antimicrobial stewardship, always keep one thing in mind. The patient we are talking about is an immunocompetent host. So usually we might err to the side of antibiotics or antimicrobials in neutropenics and in patients with immunosuppression. Adile നമുക്ക് ഇൻഫെക്ഷൻ ഇല്ലാന്ന് 100% ഉറപ്പുണ്ടെങ്കിൽ മാത്രമേ ആന്റിമൈക്രോബിയൽ സ്റ്റ്യൂവർഷിപ്പ് നമ്മൾ പ്രാക്ടീസ് ചെയ്യത്തുള്ളൂ. In OPD etc. if you don't have access to cultures and all, in neutropenic hosts err on the side of antibiotic, even though the recommendations are not like that.
One Shiba Damodar madam wants to ask some question. Please go ahead, madam.
Sir, actually, I just want to ask, clinically, many times patients comes with viral pharyngitis, we know, but 2 days, 3 days, if it is not properly, patient is symptomatic, we may suspect there can be a secondary bacterial infection, and for that we are prescribing antibiotics. So you, sir, is there actually the antibiotic prophylactic has got a this one for to prevent the infection, no, sir? So in a viral, this one, if at all we give an antibiotic, how whether is it like if next combo the or antibiotic coverage, if we are thinking of a bacterial infection, if it's if we start antibiotic at the earliest, it will be a prophylactic this one, no, sir?
Evidence antibiotic will prevent a bacterial infection. If you look at the pathophysiology of a secondary bacterial infection, what happens is that influenza and the classical case in point, that is the mucosa, tracheobronchial mucosa, abrasions or ulcerations. So the mucociliary clearance is defective and there is a bacterial colonization, and this colonization will become invasion. That is what happens in influenza, leading to secondary bacterial infection. But then you will get signs, right? So നേരത്തെ നമ്മുടെ sinusitis പറഞ്ഞ പോലെ double sickening എന്ന് പറയുന്ന പോലെ patient will improve first and then become worse later on. You will have ഈ പറഞ്ഞ പോലെ increase in secretions or purulence or fever is spiking up. At that time use antibiotics. അല്ലാതെ ഇൻഫ്ലുവൻസയ്ക്ക് this
not
antibiotic
only, sir, I didn't ask, sir, for the first day, just 3-4 days, if the patient become, we do not know whether there is an infection, but still if the patient's symptoms are not subsiding, at the earliest whether we can start. That's what I asked.
If you are suspecting a bacterial infection, you can start at the earliest. There is double sickening period. It may not be at 3 or 4 days, it may be at 5 or 6 days.
Okay, we can wait more than that.
COVID പറയുന്ന പോലെ തന്നെ കോവിഡിലും ആദ്യം ആന്റിബയോട്ടിക് കൊടുത്ത ഒരു കാര്യമില്ല. അതേസമയം കോവിഡിൽ 10th or 11th day, if you are suspecting a secondary bacterial infection, compared to influenza, the chance of secondary infection in COVID is less likely. At that time, you are justified in starting an antibiotic, not upfront. Don't think that antibiotics will prevent a bacterial superinfection. പിന്നെ അതിലെ ഒരു ഒറ്റ പ്രശ്നമുള്ളൂ, നമ്മളിപ്പോൾ ആദ്യം ഒരു ആന്റിബയോട്ടിക് കൊടുക്കുകയാണെങ്കിൽ ഈ സെക്കൻഡറി ഇൻഫെക്ഷൻ വരുമ്പോൾ ആന്റിബയോട്ടിക് റെസിസ്റ്റന്റ് ഓർഗാൻസ് ആയിരിക്കും വരാൻ പോകുന്നത്.
Is there any role of antibiotic prophylaxis in OPD patients?
No role at all, except in that situation we discussed, right? Post-coital UTI, or to an extent in diabetes with recurrent urinary tract infection, even though the recommendations are not there. Antibiotic prophylaxis role actually illa. Then I saw one very interesting question in the chat box that Cefixime is being used right and left for respiratory infections. What is your take on that? So that is one thing that we can do, because respiratory infection, if it's a pneumonia or something like that, the organism is pneumococcus, which is not covered by Cefixime at all. So Cefixime should never be used for a respiratory tract infection. One thing is that we have very good alternatives from the access category. Second is that this drug is not going to cover the pathogen which is responsible for a respiratory tract infection. The next question will be, then why did the patient become better? Patient became better even without Cefixime. It's not that all patients will die without antibiotics.